Okay, so this was a young-ish male, and they had this lesion in their liver. One of the important things about this is that, well, it's pretty T2 hyperintense, and one important thing is that it's got this big interface with the IVC here, as well as probably the middle and the right hepatic vein. So this is a really dangerous spot to have a liver mass because it's very difficult to resect this when it's involving, especially if it involves all three of the hepatic veins. So I'll show you a couple of other sequences. This was the arterial phase, and this was an EOVIS scan. So you can see that's why you've got this transient abnormal artifact, because he was hyperventilating. What'd you say?
I hate when that happens.
I know. So, but we can see that the mass does have arterial enhancement. And this is the delayed, so it was washing out. And then we did an EOVIST, and we can see that there was no retention of contrast on the EOVIST phase, even though there was contrast in the bile ducts here. So T2 bright, enhancing, washing out, no history of liver disease. And then this was the out of phase, and this was the in phase. So you can see on the in phase, it completely blends in with the liver, and on the out of phase, there is some dropout. So it's got some mild intravoxel fat throughout the lesion. So any guesses? Enhancing, washing out, T2 bright, intravoxel fat.
HNF1 alpha.
Good. So you're talking about an adenoma, yeah. And then A also says adenoma. Alina says adenoma. So yeah, this is, we thought could be an adenoma, especially it has fat. It's enhancing and washing out. One issue though is that it was a male. He did not have any history of other things like steroid use, glycogen storage disease. So we basically, in a male, you basically have to say that this has to be resected or biopsied, and HCC is in the differential. And this was resected, and it came back as an inflammatory adenoma. So just a couple of teaching points about adenomas. These are chameleon lesions. They can look like anything. They can overlap with FNH, especially if they have arterial enhancement and in a young woman. And they can also very much overlap with HCC with enhancement, washout, fat, hemorrhage, and rupturing. There are many, many different types of adenoma, but there are three main types that I like to kind of think about to wrap my mind around it. The steatotic one is the HNF1 alpha one. That's the one that Nellie was talking about. And it actually tends to usually be much more fatty because inflammatory, which is what this one ended up being, can also have some patchy fat in them. But this steatotic one has the lowest risk of hemorrhage and malignancy. So these are considered kind of the most benign ones. Inflammatory goes through a different pathway, the JAK-STAT pathway. It's in patients that are OCPs, fatty liver. This is the most common type, but 10% of these will have a combination of also having beta-catenin. These are the ones that tend to hemorrhage. And then the beta-catenin ones are the most malignant ones. These are more common in men, but also in women, and these have the highest rate of malignancy. And so on imaging, there are a couple of different features that are suggestive, although not totally diagnostic of these things. So the steatotic one is going to look very fatty. The inflammatory ones can have hemorrhage, so you might see blood. You might see kind of less extensive fat or patchy fat, the atoll sign, or sustained contrast enhancement. And then the beta-catenin ones could have washout, and some of these will also retain on EOVIST. So this is where it gets confusing, where it might overlap with an FNH. But if it looks heterogeneous or it has other features, then you should be more worried that it could be an adenoma, one of the rare adenomas that also retains EOVIST. So just a couple of examples, these fatty adenomas. So this was an example of one that we biopsied. Here's another one. It has extensive fat in it. So these ones that are the safest, they're actually thinking about trying to just do active surveillance and watching them. They don't have that much enhancement. They tend not to hemorrhage. Inflammatory adenoma, they might have blood in them. This is the atoll sign, which is basically a rim of T2 hyperintensity, and they could have the sustained enhancement, so not necessarily washing out, although they can. And then the beta-catenin one, the male ones, these are the highest risk of malignancy. So basically any male with an adenoma, they'll remove it. This is just an example of one. This one had a lot of hemorrhage in it, so you might have thought maybe this is inflammatory. It turned out to be a combination of an inflammatory and beta-catenin. It also had a lot of enhancement and more delayed sustained enhancement as well. So this is just an example of a beta-catenin one. Any questions?
There was no thought about biopsying that. It went straight to resection, huh?
This one, yeah. So we had a lot of questions about it. We said, like, basically, should we biopsy it? But because there was no retention on the eovist and it didn't really look like an FNH, we thought if it is an adenoma or possibly on the spectrum of an HCC, because he's a male, it's going to have to get resected anyway. We did think about biopsying it, but there was nothing that much else on our differential. So it went straight to resection. And actually, they were able to spare this middle hepatic vein, and the left hepatic vein often joins the middle hepatic vein. So that was like very tricky. They had this like very thin window here, but they were able to do a right hepatectomy and spare all of that. And his liver, you can see his left lobe is nice and big. So we thought he was like at lower risk for developing, you know, postoperative liver insufficiency. But yeah, you could have biopsied it. You know, we were thinking like, okay, we had to just come straight across here, but felt like adenoma and HCC were our main differential, so we'd still probably have to resect it.
But they can type the adenomas with a core, can't they?
Yeah, they can't fully type them, but they can test for beta-catenin. So they would have, if you had a core, you could say probably it's inflammatory, and then they could test it for beta-catenin. But the thinking is that in a male, they would probably have to resect it anyway. So if they got the beta-catenin or not. This one came back inflammatory adenoma and actually did not stain for beta-catenin. As opposed to this example, this was also a male, and it was a combination inflammatory and beta-catenin. So I think it could be variable, and usually in a male, they would probably resect it.
But if you could tell that a priori in some way, maybe you could have left it in place.
Yeah, and actually, so say this was a female and we biopsied it and it was beta-catenin negative, I think people would feel more comfortable with that. So, and then there's a question, was the IVC margin a problem during resection? They were actually prepared to resect a sidewall of the IVC, but they were able to just peel it away because it was in the liver, it wasn't invading. It didn't have a like high mitotic figure. It was a pretty bland inflammatory adenoma. Some adenomas, because they're hepatocellular lesions, they're on the spectrum where as they get more and more atypical and dysplastic, they can, even on final path, sometimes they can't tell the difference between a very atypical adenoma and a well-differentiated HCC. But in this case, it was just very bland and it was able to be pulled off the IVC. Okay.
I think Nicole has 6